cardiac arrest survival as the benchmark, because for so many things, it's the big sexy thing. It is the thing that matters the most. We're giving people their lives back. We're giving people family members back. Very important and critically important.
Right.
However, it was a grand slam home run in baseball. Okay. Sure. Why do we
just ask? Hey everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here from the Overrun. We are continuing our series of my hypothesis that we have no idea what the hell we're doing for cardiac arrest. And today, Dan, we're going to talk about the Paramedic 3 study, which is fun because it's a data set that's similar to a journal club we did about 6 weeks ago. So 6 weeks ago, we found out that it turns out IO might be superior to IV. And seems here from this group here, let me bring up this screen of this Paramedic 3 trial group. That's not necessarily the case. So Dan, let's go over some of the stuff they talked about in this study here.
This is kind of interesting.
So what they looked at here was they analyzed out of hospital cardiac arrest.
Okay.
The hypothesis, the argument is that giving medications and venous access is time dependent. And we'll jump down here, just quick look at the results here. We had a little over 6,000 patients, really good split in the groups, 3,042 for the IV group, 3,040 for the IO group. This shouldn't surprise anyone. At 30 days, we had about 4.5 to 5% survivability, which is something we'll talk about a little bit more in the end. And again, our conclusion here, among adults with out-of-hospital cardiac arrest requiring drug therapy, the use of IO first vascular access strategy did not result in higher 30-day survival than an intravenous first strategy. So we're going to get into some of the meat here in this actual data set. But first, Danny, let's talk about this because a few weeks ago we talked about a study that kind of talked about the opposite results here.
Yeah, and this is where you get into, one study talks about one specific set of circumstances. It's not a blanket, it's not a panacea for everything. And you really limit yourself when you kind of cherry pick a study and say, wow, this is what we're going to do because this changes everything. There's very few of those actually out there. This study was interesting because it kind of mirrors what we're seeing in the field. The numbers, the N is good. I mean, it's almost over 6,000 patients enrolled. The split, like you said, very, very equally divided arms. So not one side getting more than the other. And, again, in this study, in this circumstance, and you hear me say this almost every week, you didn't see an improvement. And overall, the big thing is you don't see an improvement in 30-day mortality. And I think that's what we really need to look at here is these people don't get better, or they don't get better enough to go home. And I think maybe what all these cardiac arrest studies and all this stuff that's coming out this year, and it's been a year for cardiac arrest studies, a lot of resuscitation-based stuff. And again, we've talked about this for years that we have not been able to get the cardiac arrest survival rate much above 10% overall. Right. And I kind of think, and this is my hypothesis, and of course I got nothing to back it up except all these studies. I hate to do this, but I think maybe we're realizing that cardiac arrest is a little bit more of a tougher nut to crack than we think. And unless it's certain circumstances, certain patients with a certain presentation, we're just looking at end of life, folks.
Yeah, and that's not to say that this is, a futile approach or a futile thing to try and or something we're trying to give up on. But again, when we look at these data sets, it just kind of confirms the rest of the data we've seen previously. So going back to this study here, we looked at the characteristic of patients here. Again, the mean age, 67, 68, pretty even split between male and female. Almost 80% of these arrests were experienced at home. They had about 20% or 19% that were shockable. Almost 56% in all the study sets were asystolic. We have initial cause of cardiac arrest. They were 80% were medical. Almost 38% were unwitnessed, right? Almost 70% had bystander CPR. Almost 23% had no bystander CPR. Public access to a defibrillator. 87% did not have access to a defibrillator. So, and just another table here before we get in, just real quick before we get into the meat of this, Dan, because I want to get into these tables here.
Okay.
Right.
I'm excited about this. So you just got to, I'll go with
it. It's a lot of interesting stuff. So time from emergency call to EMS on scene, 8 minutes. Time from EMS on scene to vascular access, 12 minutes. Time from EMS on scene to drug administration, 14 minutes. Time from emergency call to vascular access, 21. Time from emergency call to a drug administration, 24. Time from arrival of EMS to transportation, 56 minutes, right? And then time from emergency call to hospital arrival, 78 minutes. So, and then we get into the IO, IV, epinephrine, amiodarone. Here we saw 91% supraglottic airway use. And then we got into, tracheal tubes here, transported to the hospital. Again, 66% of patients not transported to the hospital in the IO route. So looking at these particular data, I think what's interesting about this, because the way this study and the one that we talked about in September, it looked at IV and IO as independent variables, right? So, and again, I think it helps to kind of answer a question that we've had sort of in the field, right? Because you'll have people who will talk about, well, IV is direct venous access. It's what we've always done. It's fast. It's in. My contention to that has always been, I'm not going to miss an IO, right? Like if you have someone who's in cardiac arrest, you don't know how, like if someone has no circulating vasculature, it's hard. It's really hard to find like a good vein, right? Where I know I'm not going to miss the humeral head. My argument for using supraglottic airways over endotracheal tubes in cardiac arrest is you can't miss a supraglottic airway, right? And so those are just my contentions. It's a time thing. So one of the things that we have to start discussing, and I think that we have to start kind of accepting in our industry and in our practice, is that death is a part of life, right? This is the natural conclusion to every life. And we've talked to, mental health professionals about it. And we've talked about, we've done death notifications. Yeah. Maybe that we have to start accepting a reality that life is a terminal condition, right? So it might be that, all right, we have to find whatever, third of the patients that we can actually help here. But as far as the medicine side of it is concerned, again, 14 minutes to the first drug. We know that 10 minutes without any oxygen circulation to the brain causes irreparable brain damage. So, I think it's interesting. I was going to say I think it's fun. It's not fun. I think it's interesting that, we're looking at all this data, but we keep trying to find this data to say that what we're doing is working. And we just keep trying to find, all right, well, maybe we're doing this thing that works. And we keep putting out data that just shows that the stuff we do in the field doesn't work. It doesn't mean it's not important, right? But we keep trying to find more and more isolated incidents in which the current algorithm for cardiac arrest will work, and it just doesn't.
Yeah, and the interesting thing to me from, sitting in on these Monday afternoon clubs and, looking at this stuff, all the data kind of sounds homogenous, doesn't it? I mean, it really is. We're seeing the same numbers. We're seeing the same times to treatment, the same age, same presentations, and we're not seeing an improvement. So, the famous definition of insanity is doing the same thing over and over again, expecting a different result. Right. And I'm not saying these people are insane, and I'm not saying this isn't an important study. I think we're building to something here. Cardiac arrest is a specific condition that has a specific window of reversibility in certain instances, okay?
Right.
If those things get taken care of, if they don't, this is not a survivable event. We also have to look at the vast majority of the cardiac arrest calls we go on as EMS clinicians are not really survivable events. How many times do you get that? How many times a year do you actually get the witnessed arrest where someone collapses, CPR started, initiated, right away, you have an AED on scene or a police officer gets there with an AED on scene, you get a good outcome? It's extremely rare because everything has to work together at the right moment. It's like a flea flicker play in football, right? Everybody's got to do, if you're off a half a step here or a half a step over, you don't get it. If the ball's a little too high or a little too low, you don't catch it. We are really trying to justify this. And I think we need to start changing how we look at cardiac arrest. Not to say that we write off everybody. I'm not saying that. Don't go back to everybody and say, well, Dan says we shouldn't do cardiac arrest resuscitation. Absolutely not. I think when you look at the mean age, okay, when you look at the mean age, you got to realize that's the average. There's a lot of people that are higher than that. There's a lot of people that are lower than that. But the vast majority of people are at 67 or older. That doesn't bode well for long-term survival. Yes, I'm
Right.
sure
Yeah.
that there's somebody in this data set that was 35 with a cardiomyopathy who dropped mowing the lawn, and somebody was right there and a witness arrest, and everything turned out great because he was 35 years old, a healthy individual. We're not getting these people in the field.
And
That's kind of that that's that golden needle in the haystack, right?
yeah.
Most of the people we get are 70s and above, unwitnessed, no CPR, AED's non-shockable, get on scene. This is a slow PEA or an assistantly arrest. And I think we're almost kind of realizing, look, this isn't going to work. So we have to start thinking about, what is this actually going to work for people?
Yeah. No, and I think that's right. And now that, we're 11 minutes into the show, I should mention this came out of the United Kingdom, the reason that matters is that this is a system that's pretty well established, right?
Yeah.
This isn't a combination of, one volunteer system, one hospital-based system, one municipal system. It's a system it's pretty well run.
This is a national health system with a national-based education system. Paramedics are everywhere. They have resources. They have, there's no bars to resources for people. This is a good data set.
Yeah, and I think what's going to be interesting, and I think where the conversation, or I guess I fear where the conversation is going to go, is, well, this happened in the UK. This isn't in the United States. And I mean, okay, but I do feel that there's a pretty strong cross-section of the population in the UK that translates over to the United States. And this is where I think a lot of providers this is where I think a lot of providers sort of let their ego get in the way of the treatment. Because I feel like in this setting, this is where we hear a lot of like, well, I don't do that, right? I don't miss IVs. I don't miss ET tubes. Right. I'm a better resuscitationist than the data shows. And that all might be true, but the plural of anecdotes, not data. Right. And so, we look at this, and what I will give them credit for is it seems like on average, they stayed on scene to work the arrests, which that's great, right? Because that's something we don't see enough of. Again, sitting here from emergency call to hospital arrival, 78 minutes across both data sets. And, and again, it goes into the drugs that were administered, defibrillator shocks and things like that. I think the attempt was probably within the current guidelines and within, the current data recommendations, which is really exciting, right? Where now we know that we can take a system, we can apply what we know, or at least what we think works best, and apply it to our actual practice. But then the frustrating part is then we publish data saying, hey, it turns out we're still not resuscitating these cardiac arrest patients. I think that, and Dan, you and I have talked about this a lot over this past year. I think that we focus on cardiac arrest because it's the most tangible thing that we can show, progress in.
Yes.
Right. If someone called 911 because, or in this case, 999, if someone calls 911 because, their loved one is dead in front of them, you get to them, we resuscitate them, they're better, they walk out alive. That's something that people can see. Right. So it kind of adds to those, like big, sexy numbers that we're always worried about. But then we don't put that same weight, that same volume onto, fixing your CHFers, fixing your COPD patients, your routine patients, where if they can't get access to primary care, all right, we can at least treat them in the field. And I wonder what the survivability numbers would be if we applied them to people with chronic conditions that have acute exacerbations. You know what I mean? Where I'm happy to see the cardiac arrest data. I maintain my original stance that we have no idea what works. We have no idea what the hell we're doing, regardless of what the presentation is. But I almost wonder if when we take this cardiac arrest data, maybe we look at it and say, like, you know what? Maybe we're just looking too much into this. Maybe there's just other ways that we could start looking at this. We need to do early CPR. We need early defibrillation. Because again, in this data set, when we look at bystander CPR, we look at people who are willing to help, it's still very, very low. Right? We had, and I accept, and again, in this data set, it was about 70% had bystander CPR performed, which is incredible. That is logarithmically higher than we'll see in the United
It's
States.
fantastic.
And
Absolutely.
right, so even with 70% bystander CPR, and well, again, so you get 70% bystander CPR, and only about 8% had access to a public defibrillator, which is a whole other problem. So, maybe instead of trying to dress up all the different sexy stuff we can do, maybe, all right, we just need AEDs out in the public, right? We put it into schools, you train people how to do basic BLS resuscitation, get them out there, get them saving people, because that's what actually works. So I worry that some of it is our ego coming into it saying like, well, I'm the one who can save you,
Yeah, it's interesting you bring that up because it just came to me in this idea. And, we use cardiac arrest survival as the benchmark because for so many things, it's the big sexy thing. It is the thing that matters the most. We're giving people their lives back. We're giving people family members back. Very important and critically important.
Right.
However, so is a grand slam home run in baseball. Okay. Why we
just ask the Dodgers.
Well, here's the thing. How many grand slams do you see on a daily basis?
Right.
How many times do you have that moment in baseball? The reason why it's so amazing, everybody goes, "Oh wow, grand slam!" It's because you hardly ever see it.
Yep.
And we don't keep a statistic for except in a real statistic wonk Moneyball kind of thing. Like, well, Dave's hit 27 grand slam home runs in his career. Yes, 27 in a 20-year career. I mean, why do we judge EMS on the grand slam home run? Why don't we judge them on, well, nobody ever talks about the greatest hitters in baseball or the greatest shooters in basketball or hockey and said, well, all the times they did the really, really wild, how many game-winning goals did someone have in the Stanley Cup Finals? It's not a statistic we look at because it's such a rarity. They judge you on goals, assists, points, penalty minutes for some of us. Like in baseball, they judge you how many times you hit the ball. They judge you on the average of how many times you hit the ball when you get up. How often you hit a run in. How often, yes, home runs count, but we don't look at the one thing and judge everybody's athletic career or a team based on how many times they do something that's so rare, we very rarely see it. And I think that's what we do with cardiac arrest. We're judging us on the biggest stakes, the highest thing, and the thing that's the most complicated and probably needs the most things to go right at the right time to get the outcome. And I think we're hurting ourselves. We're hurting the job. We're hurting the profession. This stuff is great, but it's reinforcing the bottom line is that this is not something we should be judging ourselves on.
No, and I think that's right. I like the sports analogy too. I mean, again, you and I have talked off air. Wayne Gretzky could have 0 goals and would still have more points than anybody because of his assists, which I think is an interesting analogy. But we do want to know what you guys think. Again, IV versus IO and cardiac arrest. It's something that the data is debating at this point. Paramedic 3 is going to get a lot of coverage, simply because of the follow-up to the Paramedic 2 trial. But tell us what you think. Make your comments down below. Be sure to subscribe to the Overrun on YouTube, Spotify, Apple Podcasts, and all of that stuff. Check us out on EMS1, where we do some news stories over there once a week or so. But for the Overrun and for Monday Afternoon Journal Club, I'm Ed Bowder. He's Dan Schwester, and we will talk to you next week.